111, second paragraph on the right, when a physician reports a treatment of a fracture and then applies the cast or strapping, the cast or strapping is included in the procedure. So don't try to code the casting or strapping when it's done at the time of the procedure. You only code it when they come in for removal and recasting, or when they only perform splinting or whatever. One thing that is mind-boggling for a lot of people, coders, is that you can actually have fracture care performed without a surgery. They might set it and cast it. And you're thinking, but they only put a cast on it. No, they did fracture care. It was closed fracture care. And I'm sure they've got one. It tells you the test technique, highlight keywords in the fracture care code, such as with manipulation, without manipulation, with internal fixation. Again, just like when we were coding our diagnosis codes for fracture, when you go with procedures for your orthopedic section, you hang on every word, because every word descriptor would change your code. Let's see. One other thing I forgot. HCPCS level 2 codes. It's in that book, that purple book. Your supplies. Tells you here, L codes are for orthotic and prosthetic procedures and supplies. Then this section gets the majority of supply codes, rightfully so. Tells you some physicians will provide basic orthopedic supplies, but most of them are supplied by a durable medical equipment DME provider fulfilling the physician's orders. J codes are used to report the supply of medications given by injection, IV, or intrathecally, or whatever it is. Thecally. Intrathecally? What is that? And then modifiers are often used in orthopedic surgery to indicate which side of the body, right or left. And it goes over the most common modifiers used with ortho. And don't forget your modifiers for digits. You got F1 through F8 or F9. And then TA through T9 is F1. All right, so look at number number 9, this scenario, page 115. All right, so postoperative diagnosis, unstable left distal radius fracture. Pre-op is the same. Unstable doesn't mean anything. Left distal radius fracture. The procedure is a closed reduction, and percutaneous pinning with manipulation of the left distal radius fracture. It's under general anesthesia. So if we were coding anesthesia, in this case we would code anesthesia, but we're just coding the actual procedure, not the anesthesia. 14-year-old young man here for a bowel. I had seen him in clinic earlier today. He had a bike wreck with an unstable distal radial ulnar joint and unstable fracture. I discussed with him and his mother preoperative risk and benefits, and they wish to proceed. All right. Brought to the OR, placed in the supine position on the operating table. General anesthesia induced, antibiotics given preoperatively. Left arm wrapped and draped, usual standard. Landmarks identified. Underlying closed reduction maneuver was performed with traction and reproduction of the deformity and then reduction. A near anatomic reduction was afforded, visualized with multiplanar C-arm fluoroscopic imaging. I then placed 2 K-wires percutaneously, one through the radial styloid and one through the blister's tubercle. That right there is internal fixation. It gave us adjunctive fixation of this manipulated fracture, and then fluoroscopy imaging confirmed the good placement of the implants and a near anatomic reduction. Dressing sugar tone splint was applied. Our splints are included with our major surgery. Patient was awakened from anesthesia, taken to the recovery room, stable condition, no operative complications. EBL normal, all counts correct. Okay. Can y'all do this? Yeah. What was performed? Fracture reduction with manipulation, with internal fixation. If anything, when you're at a loss, go to fracture. On the distal, where we at? Radius, on the radius. Radius. And then distal. And open. That was closed, not open, I'm sorry. Alright. 25606. Yay, nay. Nay. No. I sit here saying open, 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 and then I looked up and it says right there closed reduction, and you don't see an incision was made. I don't know where I was getting the open, and I say an open, I'm sorry. Anywho, it's closed reduction maneuver was performed with traction, manipulation, and then they did a percutaneous fixation with the K-wires. So 25606 is the percutaneous skeletal fixation of the distal radius fracture or the epiphyseal separation. They're not specifically saying closed reduction because think about it like this, they can't do a percutaneous fixation of the bones without doing a reduction. That's why they didn't just spell it out for you there. I guess that's one of those things where they can't do one without the other, and that's why it's not there. Now, if it would have been open, you would have gone down to 2, 5, 6, 0, 8, 9, but those are for internal fixations, not for externals. And then it was on the left side, so you put the LT modifier.
So 25606?
Yep. And keep in mind, when they're doing these scenarios, y'all, they're giving you guys something to think about. On a normal scenario, you're not always dealing with stuff like this. I mean, you're going to be dealing with percutaneous pinning, but you know they're giving you things to make you think. Look at number 10. The pre-op and post-op diagnosis is the same. Right clavicle retained deep hardware, so it's good to know your location. Procedure performed. Removal of hardware, clavicle deep. General anesthesia was performed. And it tells you, if you don't, I mean, think about how in the hell would they have hardware in there? So they had a previous something. And it's telling you right there, previous clavicle ORIF, open reduction internal fixation. They are now here for the hardware removal from symptomatic problems, and that's common. The fracture be healed, the hardware is still there, and it starts causing inflammation or pain, and you have to remove it. They discussed it, along with the risk, complications, understood, and then wish to proceed. They're taken to the OR, placed on the table in supine position, administered pre-op antibiotics, general anesthetic, followed by intubation by the anesthesia team. Extremity was positioned, prepped, and draped in typical sterile fashion. The previous incision was reopened down to the clavicle, so that tells you it's open. They're opening that incision, or there's an incision, whether they opened that old one or made a new one. The plate was found where it was freed up, both medially and laterally. Screws were removed, including the interfrag screws. Plate was taken out, then used a wronger to clean up the edges of the soft tissues. No prominent bone areas. Irrigated wound thoroughly. Close the deep tissue with a 2O vicryl, followed by closure of the superficial layer using 2O monocryl and running 3O monocryl stitch. Sterile dressing applied. A .25 Marcaine and epi was injected around the incision site. Dressing was placed. Patient was awakened and taken to the recovery room in stable condition. Keyword: removal. That's what they did. Like a while ago, we looked for fracture. You could have gone to repair as well and gone to fracture, but just like the diagnosis codes and the index there, you can usually get to the same place several different routes. Did y'all find it in the horn?